Hello and welcome to Triage, rapid legal lessons for busy healthcare professionals, a podcast created and produced by K&L Gates. Each episode is designed to highlight important developments in health law and analyze the impact on our clients and friends of the firm. We hope you enjoy this podcast.
My name is Gina Bertolini, and I'm an attorney with K&L Gates' National Healthcare Practice Group. Our healthcare practice group tracks the evolution of healthcare regulations, among other things, including those related to digital health and information privacy and security. Many of our listeners who have been following recent changes at the federal level related to information blocking will know that in late October of 2020, the Office of the National Coordinator for Health Information Technology, or ONC, announced a much needed and much appreciated reprieve of its November 2nd information blocking compliance deadline. ONC issued that reprieve through an interim final rule, and that interim final rule extended the November 2nd initial compliance deadline. That compliance deadline would have made ONC's information blocking rule requirements enforceable, and those rule requirements are located at 45 CFR Part 171. That's 45 Code of Federal Regulations Part 171. The reason that's important is the information blocking rule located at Part 171 was a new rule promulgated by ONC's final rule on interoperability and information blocking. The final rule was released in March of 2020, and it was published in the Federal Register in May of 2020. And as most of our listeners will know, healthcare providers nationwide in March and April and May of 2020 were in the throes of what has become an almost year-long pandemic dealing with COVID-19, and hospitals and healthcare providers, which are actors under the information blocking rule and are required to comply with the information blocking rule, were allocating precious resources to dealing with the public health emergency that is COVID-19. The initial compliance deadline was November 2nd, and as that date neared, many healthcare providers and hospitals nationwide realized that they needed more time and they needed more resources. Again, still struggling and in the midst of the public health emergency. So fortunately, the interim final rule that ONC released extended the information blocking rule's initial compliance deadline to April 5th of 2021. My colleagues and I issued a client alert outlining the interim final rule and its scope, including relevant dates. And that client alert is available on K&L Gates' website in the event any of our listeners would like more information on the interim final rule. We've provided in-depth and detailed guidance on ONC's information blocking rule through advice to clients directly, as well as through the publication of client alerts and a triage episode from earlier this year focusing on the preventing harm exception. And while we know that healthcare providers will continue to work toward the April 2021 information blocking compliance deadline, the reprieve has allowed them to take a breath and consider the entire information blocking landscape. That landscape includes not only ONC's final rule on information blocking, which I just referenced, but also the landscape includes CMS's interoperability and patient access final rule. CMS's final rule was issued at the same time as ONC's final rule, but before ONC issued its interim final rule, which extended that deadline, which I've just talked about, CMS had previously announced that it would delay compliance deadlines for its final rule. And so it stands to reason that in the wake of a delay issued fairly early on by CMS, CMS requirements were not the primary focal point for healthcare providers and their already stretched IT, clinical, and administrative resources which were sorely needed to work toward compliance on the information blocking rule. Given ONC's interim final rule, we are now hearing from many institutional healthcare providers that they are turning their attention to CMS's final rule. This podcast is intended to provide information to healthcare providers regarding CMS's interoperability and patient access final rule. And while there are many components of that rule, including several new requirements applicable to healthcare payers, this episode of Triage will focus on two components of CMS's final rule that impact healthcare providers specifically. And those components are CMS's public reporting requirement of clinicians and hospitals who are making attestations under the Promoting Interoperability program related to information blocking. And the second component is a new Medicare condition of participation, which will require hospitals, including psychiatric hospitals and clinical access hospitals, to send electronic patient event notifications. I want to emphasize that there are many moving pieces to CMS's final rule, including, as I mentioned, many that affect healthcare payers, but I will only address these two discrete provisions that are relevant to healthcare providers. And before I get into those components in more detail, I'd like to provide a little bit of context on CMS's final rule, again, sort of within this entire information blocking landscape. As I mentioned, CMS issued its final rule in tandem with ONC's final rule on information blocking. And certainly these two rules together form a package and what is a clear directive toward enhancing health IT interoperability and reducing information blocking actions by actors such as healthcare providers, health IT developers, and healthcare payers. In describing its final rule, CMS boasted that it delivers on the administration's promise to put patients first, giving them access to their health information when they need it most and in a way that they can best use it. CMS went on to say that the lack of seamless data exchange in healthcare has historically detracted from patient care, leading to poor health outcomes and higher costs. CMS also stated that its final rule would establish policies that would break down barriers in the nation's health system, that would enable better patient access to health information, improve overall health IT interoperability, and unleash innovation, and that those factors would lead to better care and improved patient outcomes while at the same time reducing burden on patients and on healthcare providers. In a publication that CMS released summarizing its final rule, it stated, and this is a quote, "In a future where data flows freely and securely between payers, providers, and patients, we can achieve truly coordinated care, improved health outcomes, and reduced costs." And that's the end of the quote. To help further the seamless and free flow of data, CMS's final rule does two things that we think hospitals and other healthcare providers need to be aware of. First, it allows CMS to publicly report eligible clinicians, hospitals, and critical access hospitals that may be information blocking based on how they attest to certain Promoting Interoperability program requirements. Just as a reminder, for those who may not be as familiar, CMS's Promoting Interoperability program is formerly known as the EHR Incentive Program, and before that, it was known as Meaningful Use. For those old schoolers who are listening, they may remember references to Meaningful Use. So this is the program that CMS established in 2011 as the Medicare and Medicaid EHR incentive programs, now known as the Promoting Interoperability programs. And it's intended to encourage healthcare professionals, hospitals, and critical access hospitals to adopt, implement, upgrade, and demonstrate meaningful use of certified electronic health record technology. As part of the Promoting Interoperability program, providers are required to make certain attestations, including attestations that are specific to information blocking. Now, those attestations themselves are not new as of the 2020 final rule, but the publicly presenting the answers to those information blocking attestations is new, and that is the new part of CMS's final rule. So to the extent eligible clinicians submit a no response to any of the three prevention of information blocking statements that are part of the merit-based incentive payment system, or MIPS, an indicator on Physician Compare will note that response. Physician Compare, of course, is at Medicare.gov. It is a website that allows consumers, really anybody, to look up eligible clinicians, healthcare providers, and to compare certain data points. The indicator would be posted on Physician Compare at Medicare.gov, either on the profile pages or in a downloadable database. And that would start with the 2019 performance period data, which is available for public reporting starting in late 2020. CMS also would include information on a publicly available website indicating any eligible hospitals, including critical access hospitals, that attest under the Medicare Fee-for-Service Promoting Interoperability Program and submit a no response to any of 3 attestation statements related to the prevention of information blocking. CMS would post this information starting with attestations for the electronic health record reporting period in 2019 and would expect this information to be posted in late 2020. So there are 2 mechanisms there for eligible clinicians that are making their attestations as part of MIPS. The indicator would be on the Physician Compare website. For eligible hospitals that are making their attestations under the fee-for-service program, any no attestations with regard to information blocking would be on a separate website that CMS has created. And just for clarity, a no attestation would be the healthcare provider's representation that it is not attesting that it is preventing information blocking or that it is not information blocking. And so in CMS's view, that would be information that would be relevant for consumers to be aware of and would be available publicly. The other part of CMS's final rule that I'd like to talk about today modifies Medicare conditions of participation to require hospitals, and this would include psychiatric hospitals and critical access hospitals, to send electronic patient event notifications of a patient's admission, discharge, and or transfer to another healthcare facility or to another community provider or practitioner. CMS believes that this requirement will improve care coordination by allowing the receiving provider, facility, or practitioner to reach out to the patient and deliver appropriate follow-up care in a timely manner. The requirement modifies conditions of participation related to medical record services. Those are located at 42 CFR 482.24. That's 42 Code of Federal Regulations 482.24, and they'll be effective in the spring of 2021. With this requirement, CMS specifically sought to use the health and safety standards that are required for providers and suppliers participating in the Medicare and Medicaid programs, so that is the conditions of participation, to further advance electronic exchange of information that supports safe and effective transitions of care between hospitals and community providers. So again, according to CMS, this will be a big step toward improving care coordination by allowing the receiving provider to reach out to the patient and deliver appropriate follow-up care in a timely manner. So to the extent either primary care physicians or other physicians that are identified by the patient as being involved in the patient's care and or post-acute care providers are alerted of a patient's, one of these event notifications, which I'll talk about in a moment, but would include discharge from an inpatient facility, then that primary care provider or that downstream post-acute care provider can proactively reach out to the patient and be aware of the patient's status. And the idea here is that will reduce readmissions, hospital readmissions, as well as the further need for acute care. Under the CMS final rule, just want to talk about timing for a minute. The new condition of participation would have been applicable 6 months after publication. And as I mentioned earlier, the CMS rule was also published at the beginning of May 2020. And so the condition of participation would have been applicable beginning November of 2020. So that deadline would have coincided with ONC's information blocking compliance deadline. CMS recognized that hospitals are in the throes of the COVID-19 public health emergency, as I mentioned earlier, and early on extended the implementation timeline for this particular condition of participation. This is the admission, discharge, and transfer notification condition of participation. They extended that timeline by an additional 6 months. And so that makes the new condition of participation effective 12 months after the final rule was published, which again, that was May of 2020. And so this condition of participation will become effective May of 2021. Just to provide a little bit of background on what the event notification requires, it specifically requires for hospitals that utilize electronic medical record that conforms with ONC's Certified Health IT program, that the hospital demonstrate that it sends notifications that include at least the following information: patient name, treating practitioner name, and sending institution name. And then if not inconsistent with the patient's expressed privacy preferences, the system would notify at the time of the patient's registration in the ED and the patient's inpatient admission, as well as, again, if not inconsistent with the patient's expressed privacy preferences, it would notify either immediately prior to or at the time of the patient's discharge or transfer from an emergency department, the ED. I frequently refer to it as ED, that's emergency department, and the patient's discharge or transfer from the hospital's inpatient service. So the events to be notified, again, just to recap, it's registration in the emergency department and patient's inpatient admission, as well as either immediately prior to or at the time of discharge or transfer from an emergency department and discharge or transfer from the hospital's inpatient service. The entities or individuals to whom the hospital must make a reasonable effort to ensure that the system sends these event notifications are those that will require notification of the patient's status for treatment or care coordination or quality improvement purposes. And those would be all applicable post-acute care service providers and suppliers, as well as either the patient's established primary care practitioner or such other practitioner or practice group or entity that the patient identifies as being primarily responsible for the patient's care. So with regard to which providers are appropriate in terms of receiving these event notifications, some commenters to the proposed rule wanted a more restricted requirement, and some thought that the requirement should be expanded. So like with most proposed rules, there were advocates on either side of the spectrum. CMS indicated in its commentary to the final rule that this requirement is really only intended to set the minimum floor or the baseline approach. And it specifically recognized that there may be other entities that could benefit from receiving patient event notifications. It ultimately concluded that it would establish the minimum requirement, which would be to the patient's established primary care provider, in addition to the applicable post-acute care service providers and suppliers. CMS added the use of the term established, and in CMS's opinion, the term established in reference to primary care contemplates a care relationship that the patient recognizes as primary, but CMS went on to say that patients can offer other practitioners who should receive the event notifications, and healthcare providers likewise may seek to identify other practitioners who would be relevant to the patient's post-discharge care. And would benefit from receiving patient event notifications. So the baseline is as I've described, but it will be important for healthcare providers to communicate with patients regarding primary care providers and others who would be appropriate to receive information that would be relevant to post-acute care. So we recommend that healthcare providers send event notifications to primary care practitioners identified by the patient, while also allowing the patient to offer other practitioners who are involved in the patient's care and who would benefit from those notifications, either in addition to or in lieu of the primary care practitioner. Notably, CMS's final rule does contemplate that any disclosure should be consistent with the patient's stated preferences. And this is an important aspect of actually both ONC's information blocking rule and this portion of CMS's final rule on interoperability. Both agencies, ONC and CMS, recognized that these rules are not intended to change HIPAA. In other words, HIPAA's privacy rule still establishes permissible use disclosures and accesses. So, of course, any disclosure by a hospital would be consistent with HIPAA. And this disclosure, in terms of the event notification, is for care coordination and treatment. That is a permissible disclosure under HIPAA, but healthcare providers should listen to and respect their patient's privacy preferences. And so if a patient proactively instructs a different disclosure or in fact restricts disclosure, then the healthcare provider would respect the patient's wishes. Along those lines, we do recommend that healthcare providers take reasonable steps to identify, based on information available to it, other practitioners who would be relevant to the patient's post-discharge care, and would also send event notifications to those providers, again, consistent with applicable law and with the patient's expressed privacy preferences. The revised condition of participation is, as I mentioned, it's at 42 CFR 482.24. That's the medical record services condition of participation. And CMS has indicated that, as with all new or revised condition of participation requirements, it will issue new interpretive guidelines, which would include survey procedures for the state operations manual, and it would do that prior to the final rule's effective date. CMS further stated that it would advise and train state surveyors on the new requirements, as is the normal procedure for new or revised conditions of participation and standards. It is helpful to understand that this new condition of participation is within the medical record services condition of participation requirement, which currently advises state surveyors in assessing a hospital or healthcare provider's compliance with this condition of participation to view various components of the hospital's medical record systems or processes that are in place and that are operational to determine overall compliance with this requirement. Surveyors, we expect, will approach this new requirement in a similar fashion and apply similar survey procedures. And CMS actually says this in commentary. And so essentially says that this new condition of participation will not require surveyors to have deep technical knowledge of various systems to determine compliance. So we expect that the mechanisms by which state surveyors will assess compliance with this new condition of participation would be consistent with the mechanisms that are currently in place for other medical record service conditions of participation. We will continue to look for guidance from CMS on this new condition of participation, and we will provide updates either in the form of a client alert or a triage episode as those are released. We are always available to answer questions directly. My contact information is available on K&L Gates' website and will be available through this podcast. Again, my name is Gina Bertolini. I'm a partner in the Healthcare Practice Group, and I am delighted to have brought this segment of Triage to you today. Thank you so much for listening.
Thanks again for listening to Triage, rapid legal lessons for busy healthcare professionals. New episodes are available for download through iTunes, Google Play, and other podcast applications. By subscribing to Triage, you will receive timely notifications of each new episode. Also, if you have any topics that you would like to hear discussed on Triage, please don't hesitate to email triagesupport@klgates.com. We would love to hear from you.